First off, hello and welcome. My name is Mandy Gadone, and I'm the Product Marketing and Creative Manager at Jeenie. I will be our taskmaster for the event to keep us on track. First off, I'd like to cover a few housekeeping items for the event before we begin the talk with Dr. Bill Rivers. So looking at the right side of the Crowdcast screen, on your right, you'll see three areas where you can engage in the chat, and the Q&A and the polls. So the chat is open, as many of you can see already, and we will be moderating it. However, if you have questions, I strongly suggest you share them in the Q&A. We'll be putting this in our live, or using this as our live Q&A with Bill. It also has a cool feature. You can upvote questions. So if you'd like to hear an answer to a question that's already been listed by someone, you can simply upvote them. So this helps us to see what questions are most important across the community and address the most relevant ones in the limited time we have. Lastly, we have polls. We have one poll already waiting, and we're going to be asking a few more over the course of the event. So simply pop in to give your answers. Again, this helps us to gauge the audience and your interests. And then a special message for interpreters. Hello, we are happy to have you here and appreciate that this topic also impacts your world. However, for our Q&A, please note that this event is for organizational leaders who are impacted by current legislation. That's like healthcare, business, and immigration leaders. So we will be focusing on their needs and perspectives, specifically in the event, though there is overlap, of course. Okay, so that is our housekeeping. Let's dive in. Now, I'm sure a few of you are new to Jeenie, and I just want to very briefly tell you who we are and why we are hosting an event like this. Jeenie is about communication. When every second counts, we offer world-class medical interpreters in over 300 languages on our remote interpreting platform. And then clients are matched pretty much instantly to vetted live interpreters 24/7 on any device, anywhere, anytime. In line with our role as, well, truly an innovator in our space, we are also developing safe and responsible AI-based features and services, all without losing the human in our services. Okay, so now this topic is really close to our hearts and our mission. We believe that communication is a human right. Without it, it is impossible to advocate for yourself. Language makes access, connection, and equity possible. Every single day, our team gets to see the life-altering, even life-saving impacts of clear communication and language access on our platform. And that's why we're here. But let's get into the main event and what you are here for. Without further ado, I'd like to introduce our speakers. And as they're settling in, I will also share a roadmap for our webinar on the screen. And you will also see additional slides as we go through to keep you on track as to what the topic is and what we're covering. So joining us from the road is our expert, Dr. Bill Rivers. Bill is a principal at W.P. Rivers and Associates and the chair of the National Language Access Coalition. He is a former Russian English translator and interpreter, a Russian teacher, academic researcher and administrator, and for-profit and nonprofit executive. He has more than 35 years of experience in language advocacy and capacity at a national level, with significant experience in culture and language for economic development and national security in the intelligence community, private and academic sectors. He has published across several topics, including second and third language acquisition research, proficiency assessments, program evaluation, and language policy development and advocacy. He received his PhD in Russian from Bryn Mawr College. And our moderator, Dr. Richard Brecht. Richard is a Jeenie co-founder and board member. He also is a nationally recognized expert in language policy research and education, a Harvard-trained linguist and professor emeritus at University of Maryland. He has founded and led several major language organizations, advised U.S. policymakers, and authored influential work on language acquisition, national strategy, and multilingualism in education and the workforce. Dr. Brecht, the floor is yours.
Thank you so much, Mandy. I will very briefly just say that I've known Bill Rivers since he was an undergraduate at the University of Maryland and continuing as one of my students at graduate students at Bryn Mawr College. He is an incredible person with regard to commitment to language and healthcare, and he is fluent in Russian and Kazakh, and I assume Irish Gaelic, Bill, and French, and I don't know how many languages. And he has a memory that is second to none. I can't think of anyone, I don't know anyone more qualified to launch this conversation, especially now in these perilous times. Okay, Bill, it's all yours, pal.
Yeah, thanks for that, and this ridiculous introduction. Some of it was true. My name is Bill Rivers. I did go to Bryn Mawr. The rest is somewhat exaggerated. Language access is, as Mandy pointed out, we consider communication to be a human right. That's grounded in the UN Declaration on Human Rights, for example. In the United States, language access is a civil right, and it has a history. So it derives from Title VI of the Civil Rights Act of 1964, which prohibits discrimination based on race, color, religion, and national origin. Those protections themselves are rooted in the United States Constitution. The Fifth Amendment, which guarantees everyone in America, citizen or otherwise, due process. The 14th Amendment, which guarantees everyone in the United States, citizen or otherwise, equal treatment before the law. In 1974, the Supreme Court issued a unanimous ruling in the case of Lau versus Nichols, LAU. A Cantonese American family was the lead plaintiff on a class action lawsuit against the San Francisco Unified School District. The superintendent was the Nichols in the case. Supreme Court, in a unanimous ruling, said that the discrimination based on language status for those who do not speak English is tantamount to, equivalent to, part of national origin discrimination. And since then, we've seen, that's 51 years ago, we've seen the evolution of language access as a right and a language industry that helps to make that, to fulfill that promise. It's important to point out a couple of things that bear directly on what Jeenie does and those numbers that Mandy put out. Jeenie provides services in more than 300 languages. The United States is incredibly linguistically diverse. A recent book published by a fellow named Ross Perlin, Perlin, called Language City, shows more than 700 languages just in New York City. You could add probably 100 more languages elsewhere, especially native First Nations language, Alaska Native languages that aren't necessarily in New York. The U.S. is incredibly linguistically diverse. This Title VI says that no one shall be discriminated against. So if someone shows up in an emergency room and they need a Karakalpak interpreter, or they need a Lesgi interpreter, or Zarma, or Bravanese, and on, there's an obligation to try and find that interpreter. You can't say, oh, it's just too hard to find, or it's a small community, et cetera. Then that's the 300 number. That yes, Spanish is the dominant second language in the U.S., but it's one of more than 700. 24/7, 365, especially in healthcare and in legal services. Just because it's 2 a.m. on Christmas Eve does not mean that the person who shows up at the emergency room at Holy Cross Hospital in Silver Spring here in Maryland needing an interpreter doesn't get one. And that's part of what Jeenie fulfills. The Clinton administration issued an executive order, 13166. There's going to be a lot of numbers and digits and stuff thrown around. It's not critical. But that executive order required the federal government to provide language access, if needed, in its own programs, and that any federal contractor or grantee was also obligated to provide language access. It's an executive order, so it's not a law. Congress passes the law. It's not a regulation. The regulations are developed by Department of Health and Human Services, for example, with respect to the Affordable Care Act, Obamacare. Regulations have force of law, and there's a formal process by which they are developed. An executive order is binding only on the executive branch and can be revoked at any time by any president. But what Executive Order 13166 also did is it required the creation of guidance on the provision of language access in federally funded programs. And that guidance, imperfect as it might have been, and as it went through subsequent revisions in different administrations as it improved, was actually really a critical piece of critical set of information, of data for healthcare providers, for state and municipal agencies on how to go about providing language access and what the requirements were. And then the last piece of the legal infrastructure for language access is the PPACA, the Patient Protection and Affordable Care Act, also known as Obamacare, Section 1557, which has all of the non-discrimination provisions. And then, most importantly, the regulations that were developed to implement that. The most recent publication of those regulations was just about a year ago in May of 24. Those regulations, the law itself just does not call out language access or language status as a protected category. It does have national origin as a protected category. The regulation includes language access, and it includes communications access for the deaf and hard of hearing. Again, the law itself doesn't say you provide a sign language interpreter or a tactile interpreter or provide Braille materials, but those are the primary ways that you provide communications access for people with those different disabilities. Now, the Trump administration has issued 2 executive orders, Executive Order 14224 and Executive Order 14281. Executive Order 14224 did 3 things. Declared English the official language. I'm not going to talk about that. That's a subject for a different webinar. And that, again, this binds only the executive branch. It revoked Executive Order 13166 and required federal departments and agencies to revoke any guidance that was based on Executive Order 13166. But it's crucial to remember, Executive Order 13166 in and of itself was not the vehicle that required language access. It was not the mechanism, the legal mechanism that requires language access. That's the Supreme Court case, Lau versus Nichols, and a number of subsequent cases. That's Title VI of the Civil Rights Act. It's also Section 203 of the Voting Rights Act. It's in obviously the Obamacare regulations and so on. Because executive orders cannot change the law, number one, and number two, they can't overturn Supreme Court cases. Lau versus Nichols, 1974, 9-0, still the law of the land. But what it did is it made it forced agencies across the government to start taking down guidance off of websites, making it hard to find that information, meaning the guidance is no longer current, right? That's not the official position of whatever Department of Education or Health and Human Services or Homeland Security. And that was has potential to be kind of damaging, especially because there was a lot of guidance published in 2023 and 24 that really updated the original guidance from Executive Order 13166 and had a lot of any number of very important points that recipients of federal funding, like pretty much every healthcare provider, could look at and say, okay, this is how we provide certain types of language communication access, such as through relay interpreters, or the use of machine translation and AI is bounded. There are guardrails in some of these guidance documents about using machine translation and AI for interpreting. The second executive order that impinges directly on language access is Executive Order 14281, which does away with, or declares that the legal theory of disparate impact liability is no longer valid. So there are two types of discrimination recognized in case law in federal court, federal court decisions, Supreme Court decisions, and in some pieces of legislation, although not in Title VI. Title VI just says it shall not discriminate. There is disparate treatment and disparate impact. Disparate treatment is no Irish need apply. That is discriminatory based on a specific protected category, in this case, national origin. My grandmother had a sign that she yanked from someplace in Hartford, Connecticut in 1928. This isn't just the 1840s. This happened well into the 20th century. It said no Irish need apply. That's illegal on its face, and it carries the presumption that it's deliberate and malicious, right? You're saying no Irish need apply, you're deliberately discriminating, and it carries animus. The second type of discrimination is disparate impact. Sorry, Bill, we don't hire redheads. So you're not picking on the fact that I'm Irish American. Hair color is not a protected status. Will it exclude all Irish? No. Will it exclude maybe some Scots and Welsh and other people who happen to have red hair? Sure. Is it deliberate? Hard to tell. Not on its face. It might be, and sometimes these are, benign. You might have tests required for employment or things like that are discriminatory because of their effect. Now, why does this matter for language access? Because another Supreme Court case, bear with me here, Sandoval versus Alexander in 2003, Senora Sandoval was a Mexican national who wanted to get a driver's license in Alabama. Alexander was the head of the MVA, I guess the DMV, or maybe the Attorney General, I forget, and was not offered, didn't speak English well enough to take the written exam in English, and was not offered the opportunity to take the exam in Spanish. And this was ruled as discriminatory by several layers of courts, state and federal courts. Alabama kept appealing. Eventually, they lost on the language access part because it was discriminatory, and they were providing written exams in languages like German and French for the executives of multinational companies that were building, facilities in Alabama and factories and such. But the Supreme Court also said that under disparate impact liability, that is, it's not on its face discriminatory. Under disparate impact liability, the individual does not have a private right of action. So if someone says, sorry, Bill, we don't hire redheads, I can't sue them. I can file a civil rights complaint, but I can't sue them. And then it would be up to whatever Office of Civil Rights receives that complaint to decide whether there's going to be an investigation. Now, why does this matter for language access? Because that is how language access has been enforced for the last 24 years, that you file a civil rights complaint against whatever entity failed to provide language access. And then it's up to the government whether they investigate that and what happens. That sounds maybe a little disheartening on its face, but actually the history of the last 24 years is that nobody wants to be investigated by the federal government. And usually, if there is a valid complaint, changes are made, a consent decree is agreed upon, et cetera. And the government does have the right to sue if need be, and has done so in a couple of cases. So that's sort of a background now. There's a lot of other stuff going on in the Trump administration, and there's quite a number of actions that are explicitly aimed at reducing immigration, both legal and otherwise, and at removing people here from the United States who might not have legal status to remain. The concern I think we have from the language industry side is that we're going to see fewer people seeking health care or going to their regular medical appointments and showing up for healthcare only
Uh, we've lost Bill just for a second, but let me just note that what he was talking about, basically, we have all of these actions with executive orders and so on. However, what is the impact? The impact is more, we're protected legally for the most part, but the impact now is creating fear among immigrants. And they're faced with a contradiction because now they're not getting enough language support, or they're not asking for enough language support. And in the meantime, the Trump administration has drastically reduced the support for English language learning. So if recent immigrants and heritage communities in the United States basically are now being, the language services are now being diminished by demand or by funding. And if language and their ability to learn English, which is the demand of almost every administration for years and years, that English is our common language, they're caught in that dilemma. They can't use their language and they can't get English. And that's part of the problem. Wait a minute, Bill. So I'm just finishing now. So you go ahead. I just wanted to emphasize something before we lost you. Are you with us now?
Can you apparently can't see me.
Go, but we can hear you.
All right. So I'll just go on and we'll sort the image out later.
Go ahead.
The Big Beautiful Bill Act, the House version of the Beautiful Bill, has any number of very technical provisions that would have the effect of severely cutting the number of people who are enrolled in Medicaid, Medicare, CHIPS, which is the Children Health Care Insurance Program, and other federal programs. It's a reconciliation bill. So under the Senate's rules, that it can only affect budgetary matters, but not actual spending. And you say, okay, well, isn't that the same thing? Well, no. The Congress sets a budget, and then it writes a law called the appropriations laws, or a law or multiple bills that actually appropriate money. This is the title. This is the first Article 1 authority Congress has under the Constitution. The government cannot spend money unless Congress raises the money. So reconciliation bill can't affect the actual spending. And the way that works in the Senate, there's the Senate parliamentarian who reads the bill and says, okay, this provision is out of order. It has to be stricken from the bill. And pretty much all of the healthcare provisions, as of early this morning, have been stricken from the bill. And then the majority leader in the Senate, Senator John Thune from South Dakota, I think he's South Dakota, said they're not going to overrule the Senate parliamentarian. The reason they're doing that is there are a number of Republican senators up for election next November in states where they're going to be booting a lot of people off of healthcare, and they don't want to do that. They're looking for a way to vote no without actually voting no, without actually defying the president. So we're back in this flux. You know, that poll that came on at the beginning, like, what's your level of knowledge? And I was like, I think I had a pretty good level of knowledge, but man, everything's changing so fast. But then what's the bottom line? So real world healthcare impacts, you know, so we're not clear that there are going to be Medicaid rollbacks. Right now, as of right now, there won't be Medicaid rollbacks. Okay. Is there strain on ERs and hospital services? Absolutely. Payments have been delayed from Medicare and Medicaid. Those payments go first to the states, and then the Medicaid payments go to the states. The states then disperse them to the service providers in the state. Those have been significantly delayed, and that means that healthcare providers are slow to pay their bills, which, you know, it affects everyone. But presumably that money is still going to be there, and it'll eventually be flowing normally. What we are, I think, also concerned about is having more sicker patients show up in ERs rather than going to routine health visits or sick calls with your primary care physician, and, you know, dealing with problems early on. And then if people are avoiding that and only showing up when they're really sick, that's going to put more strain on the system and everyone who works in it.
Bill, can I just point out, and I know you know this, that in the Senate bill, Medicare cuts are a 2.83% physician fee scheduled cut, and across the system, right? In Medicare, even. So I know you know that, but I just wanted to put that out, that that's going to be there if that bill passes, or will that be eliminated?
The Senate parliamentarian has not issued a ruling on that yet. Okay. And there are a number of senators who are themselves physicians, including the chair of the Health, Education, Labor, and Pension Committee, Senator Cassidy from Louisiana. That's been a political football every year, okay. And it's always a point. It's always a point of contention between the physicians on the one hand, the AMA, American Medical Association, and all of the other physician organizations.
I didn't mean to...
Maybe it'll happen. Maybe it won't.
Okay.
I wouldn't be surprised if either outcome occurred, to be honest. I think
that affects the emergency rooms and everything else in hospitals and rural.
Oh, yeah.
Go ahead.
Well, yeah, it affects any doctor who's taking Medicaid, and Medicaid covers remember, Medicare is for the over 65 population. I'm not sure what the politically correct term is, Dr. Breck, to label people like you. I can't say geezer, elderly,
But go ahead.
People of a certain age. So Medicare is for the older population, and everyone pays into that through your payroll taxes. Medicaid is for people who cannot afford insurance otherwise, and it's means tested. There's a minimum, maximum amount you can make as an individual or a family before you're eligible for Medicaid. It also covers disability services and some other things, and that is about a third of the nation's. About a third of the people who have health care coverage get it through Medicaid. It's an enormous amount of people. Yeah. And then when you add Medicare in, so it's very hard to find a doctor or a healthcare provider who is not taking Medicare and Medicaid and CHIPS, because there's so many people depend on it. So what about the ROI? And this is, right, so we say, okay, so language access it's a human right. There is a moral case for language access. It's the right thing to do. Whether that matters in this political moment or any other political moment is a different discussion. There's the civil right as established in Supreme Court case law, a small number of other congressional laws and so on, and in regulation. There's a practical case. There's the first point is, and I think this gets lost when we talk about language access. Anytime there's an interpreter, there are two parties to that conversation. They are both getting language access. We frame language access as a right for the limited English proficient person or the deaf and hard of hearing person. But that doctor, that school counselor, that judge needs language access too in order to do their jobs. There's a practical case that these services don't function without it. And they certainly don't function as well. There's, and so this slide, what do we know about the return on investment of language access? So in healthcare specifically, and Dick is part of a much larger, working on this project with 670 research papers published over the last, 25 years. We know that if good language access is provided in healthcare, there are fewer readmissions. People don't end up back in the hospital. You avoid malpractice claims, that there's better compliance and cost avoidance. You're avoiding costs for compliance. We know that patients have better outcomes. There's something called patient adherence to instructions. If you give instructions in a language they understand, whether that's on discharge from the hospital or it's with a prescription, how many pills do you take? How many times a day? Do not take too many pills. Do not take this medicine with grapefruit juice or whatever the instruction is. You give those instructions in the patient's language, they're much more likely to follow them. And that leads to better healthcare outcomes. There's also evidence that under Obamacare plans, the provision of language access correlates with higher the higher patient satisfaction scores and a higher likelihood of patients to indicate that they would recommend that particular medical practice or service. That has direct financial implications because there are incentive payments tied to that in Obamacare that healthcare facilities can get, and there are penalties if they drop too low. So there's a financial case that says, specifically in healthcare, provide language access, you're going to have a better bottom line, right? Now,
Bill,
Could
I add one sentence to that? Here, from my college at Mass General Brigham, Gezer Hortez, who says, for most large healthcare hospitals, this could add up to tens of millions of wasted provider surgeon time a year. What a summary.
Right. And that's direct hit on the bottom line if you're not providing language access. There are always challenges, and it took me a while to realize that these are evergreen challenges. The first is there's an education issue. A significant number of people on both sides of the conversation, whether they're patients, litigants, doctors, nurses, judges, etc., don't understand that this right exists, and do not understand that they have the right on the one hand, and they have obligations on the other hand. Even though language access is required for accreditation of medical providers, and from the Joint Commission on Hospital Accreditation, if you are not accredited, you cannot accept federal funding, and we just covered that. That's like 2/3 of the healthcare market. It is also required as a condition, language access, for the accreditation of healthcare plans, your Anthem, Blue Cross Blue Shield, Kaiser, et cetera, for the insurance plans. So even though all of that's there, it's required for accreditation, so it's a civil right, it's required by regulation, in some cases by the law itself, providers may not understand that they have that obligation. Or, the patient will come in with their 10-year-old daughter, and the physician will turn to the daughter at the oncological surgery consult and ask the daughter to interpret, which is completely inappropriate, which is excluded under federal regulations. It's excluded under state law, where those states have laws on language access, like Maryland and New Jersey and California and others. But it still happens too often. Sometimes that's because
pretty good. You give us a kind of
wrap up.
Maybe a little bit ways of actionable, maybe just
sure.
We're going to go to quick Q&A. It's not end. We're going to go to Q&A.
Yeah, language access is still the law. It is still a requirement. It's still the standard of care in healthcare. We are watching to see if there's a chilling effect on all this other immigration stuff going on, if that's going to reduce the number of patients coming in, therefore the amount of language access. It is still a standard of care, still required, as I said. AI, and I'm also chair of something called the Safe AI Task Force, stakeholders advocating for fair and ethical use of AI in interpreting. I don't see AI replacing interpreters in those physician consults in the emergency room. It's the technology is not there, and it might not ever get there. That's another thing, that the hype is enormous. Is it going to have an impact? Yeah. Will it be used in other circumstances? Yeah. But for the critical interactions, which is really what we're talking about, I don't think AI is going to impact. And finally, the U.S. Commission on Civil Rights has a ongoing project to assess the impact of language access, the provision of language access, whether under previous executive orders or currently. I had the privilege of testifying in March, and just yesterday spoke again on another webinar with the commissioner who started this project, Commissioner Glenn McVinty. So you're going to see more coming out of the U.S. Mission on Civil Rights. it will make recommendations to the Congress and to the White House early next year. We may see some legislation that actually strengthens language access as a civil right, something that has bipartisan support actually in the Congress. Whether the president signs, it's a different question. So I'm not
pessimist.
I'm guardedly optimistic. I'm not in the place. We had a couple of rough months there around this, but as of right now, language access is still the law of the land, and it's still the standard of care in the United States.
Super. Bill,
I'm going to try and refresh so I can come back on camera. So I'll let Dick vamp.
We're going to go to Q&A. Mandy, you want to take it over? Bill, that was fantastic. Good for you.
Okay,
Mandy.
he should be back hopefully in a second. We'll see if we can get him on video. But we have a couple Q&A questions. So if you have additional questions, you can throw them into the Q&A tab. Over on the right side of the screen, you'll see the question mark icon. And in there are some questions. You can also upvote them. And let's see here. I'm actually going to move both our speakers to the main floor here. And let's just do it this way. So, Bill, I've got a couple questions that have come up. One, several very high votes. So first one is, given the evolving regulatory landscape, what do you think is the biggest misconception healthcare leaders have about language access? And how do we begin to shift that mindset?
The biggest misconception is that it's an unfunded mandate. And this doesn't really depend on the changing landscape. Yes, it's unfunded, right? But as I and other people have pointed out over the last few years, you don't get extra money from the federal government for providing people the civil rights that they're entitled to. Okay? You don't get extra money for not discriminating and for, you don't get extra money for just doing the right thing. It looks like an unfunded mandate because unlike other civil rights, it's very easy to put a price tag on it. And then you're as somebody's in a healthcare system, you're saying, oh, how do I pay for this? I've got a budget line for it. And there's no obvious place to put it. It's supposed to come out of your capitation fee for Medicare, Medicaid, et cetera, or maybe the state pays some of it, like Oregon, or maybe your state signed up for the partial Medicaid reimbursement, et cetera. One of the things we've been working on in Congress over the last 15 years is trying to get language access, actually get a billing code, so that just like when you get a physical therapist or an occupational therapist spends time with you after you had your knee replaced, the interpreter time can actually be itemized and billed to the insurance, which will create other issues. And then there'd be a discussion with Department of Health and Human Services over the rates that get reimbursed, and alluded to that earlier with respect to the doctors. We're not anywhere near that right now, but I think in the longer term, we probably will see that. But the misconception is that it's an unfunded mandate because, as Dick and I just talked about, there is a return on investment here. And if you can save tens of millions of dollars of wasted physician time, very expensive time, right, that could be spent treating other patients, well, that is also can be quantified. And I think that's the biggest misconception, that this is somehow a burden. Now, Dick tells a story of Bill, visiting a health.
Stop you because.
All right, just go on. Next question.
We want to get to a couple more questions if we can.
Yeah,
you got the great answer. Just
press the button and I'll stop.
I wish that's not worked for 40 years, Bill. So anyhow.
And this one, there might be a little bit from both of you on this one, but it does ask what legal regulatory change would you say is likely to have the most far-reaching impacts on language access right now for healthcare? And do you expect those changes to stick or revert?
So I think a significant revisions to something called 45 CFR 92. It's Volume 45 of the Code of Federal Regulations, Chapter 92. And that's where the language access requirements, language and communications access requirements are codified in federal regulation. And changes there, because you have to do the things like provide, notice of language assistance being available and so on. Changes there could have an immediate impact. and could be reverted, because the next administration could do just as the Biden administration did, say, okay, we don't like this, or we don't like those changes, we're going to revise it again. That would be the biggest change. Now, HHS doesn't get to determine the standard of care. That's done by the accrediting organizations. So HHS doesn't get to determine the ROI. That's often, that's that complex interplay of what's being paid by whom. The malpractice carriers have something to say about it, and so on. So, but there could be some changes, especially in the nitty-gritty details of what healthcare systems are required to do, what kind of staffing they have to have around language access, and so on. But I don't expect that anytime in the immediate future. Part of it because the people who would write such a regulation would be at the Office of Civil Rights and the Office of Minority Health in the Department of Health and Human Services. Office of Minority Health has been eliminated, and the Office of Civil Rights has been cut by 2/3. So I'm not sure what bandwidth they have. Now, I may be whistling past the graveyard. I'm sorry to use that metaphor in a multilingual audience, multicultural audience. I may be being willfully naive about that.
Thanks, Bill. And Mandy, you got another one. We have one more question, you think?
Yeah, I think so. And Richard, I just didn't know if you wanted to add anything to that answer.
No, I'd rather get another question. Thank you.
All right, you got it. So this one you alluded to in your earlier discussion around ROI, Bill, but should we expect fewer LEP patients and users requesting interpreting services given the changes we're seeing across America? I'm kind of summarizing this into something smaller, but it directly impacts both the providers and the interpreters.
So where we're actually kind of seeing the chilling effect is school attendance. And the children of undocumented parents or children of parents who might have a status that could be potentially revoked aren't showing up in schools as much, or weren't showing up school years over, basically. And I think that's out of parents fearing that they'll be separated from the kids. But even that's mostly anecdotal. There's an article today in the Washington Post that Dick was talking about before we came on, where there's a lot of showboating around what the administration is doing, but the actual numbers of people being deported aren't particularly different than they were under the Biden administration. They're being maybe louder and nastier and cruder about it, for sure. So what we have to do is we have to wait to see what the real effects are in terms of patients showing up for medical care, parents showing up for meetings with the school, et cetera. So far, anecdotally, we're seeing some chilling effect, but it's not, I wouldn't say it's systematic, not yet. And that is, it's like we have to wait and see.
Could I just comment on that maybe as a final statement? Around the world, administrations or governments that are based on kind of illiberal policies or patriotism or ethnocentrism, we've always had those with us. That's nothing new. That goes back to the history of mankind. But as I would quote, the arc of world populations tends towards diversity and towards race, in race, ethnicity, and language, basically. And the U.S. is an immigrant country, all but our indigenous populations. We are all either immigrants or the offspring of immigrants. And recognition of the need of these people, our need, all of our needs, is not going away. And it's particularly now important with social services, and particularly in healthcare, where the understanding of what healthcare can mean. We used to, when I was young, we just didn't go to dentists. We just didn't. Behavioral health was, what are you kidding? Mental health and so on, and everything. This now is undeniable in the United States. And as a final point I might put out, interpreters are not going away. As Bill pointed out, AI is not getting rid of interpreters, and the human element in human communication is inevitably permanent. And I'll turn it over to you, Bill, Mandy, but thanks, Bill.
Yeah, that's great like flow into actually, I'm combining two questions here, but it really does match well. One saying, agreeing with you, Bill, I don't see AI replacing interpreters in-person medical consultations either, but I do see family members or friends acting or interpreting more and more often in delicate health situations. And they go on to say, I see this as one of the largest burdens in the argument for return on investment that should be tackled head on in order to legally reinforce spaces for professional medical interpreters and for quality of care. And then the follow up on that was someone was also asking, oh gosh, I've now lost it. How do we make sure that in these situations, people are getting the language service help that they need? Like, how can we assist them if you're in the medical practice? How can you make sure that is happening? So I think those two kind of feed nicely into each other.
Yeah, sure. So the use of ad hoc interpreters, family members, community members, yeah, it's still far too prevalent. Part of that comes back to education. Part of it, if people can still file civil rights complaints. I understand that's much harder now, and there are lots of reasons why immigrants might not be as willing to file civil rights complaints. They're worried about their own status, or they come from a place where interacting with the government was never going to result in anything positive. Understand, but it's that avenue is still there, and part of it is educating the staff and making sure there's an easy button. Right. And there's so many things that front desk nurse, the charge nurse has to deal with, or the receptionist in the OBGYN department has to deal with, so that there's an easy button and they don't have to go into, their back ends of their organizational website and figure out how to provide language access. And it's one of the recommendations I make all the time. You have to train the staff and you have to give them a link, a permanent link on, it's floating on their intranet site. There's a phone number taped to the wall, right?
I'm going to interrupt you just for a moment by saying Jeenie now is involved in putting the power in the hands of the patient, not exclusively in the hands of the provider. That's exactly what we believe is the real approach to this. Is while we have to educate the providers, we also have to put power and educate and put power in the hands, so they walk in with a phone as soon as they walk in, and they can determine when they get interpretation. It doesn't always have to be dependent on the provider. And Mandy, I think we have to wrap up if I'm not mistaken.
We do. We went a little bit longer. But if there's any closing comments, we got just a few, like 30 more seconds to just wrap this up between the two of you, Bill, and then Richard. We'll close this event out.
Well, I really appreciate the opportunity to talk to this audience. I've been involved with Jeenie myself since the days of when it was something else a long time ago. And what we're doing, the work we do makes people's lives better. And that will continue.
And I can do nothing more but second that and thank all the interpreters, all the healthcare providers, and all of the policymakers who listen to this and give us feedback. And we are united in this country and around the world that these languages are not an obstacle. The Tower of Babel was the mistake, and the God corrected that mistake by mandating languages across the world. I'll end with that one.
Okay, so I'm just going to pop onto our last screen here. So one quick note, we will be sending out a follow-up email to all attendees and sharing a couple of resources, and there will be the option to rewatch the webinar at a later time so you can really digest what's been shared here. But of course, big thank you to Bill Rivers and to Richard Brecht, both doctors, Dr. Bill Rivers and Dr. Richard Brecht, for their time, their insights, and the information. They have shared their email addresses, so if you would like to reach out to them, you absolutely can. And here's to communication for everyone and language access. Hope you all have a great rest of your week.